So it's officially 8 o'clock, at least according to my clock here. You will see that there's really not a PowerPoint for today. There's a couple of reasons for that, starting with yesterday I was totally exhausted. So to a degree, it's a little bit me just running out of gas. But I had also, previously I had signed a bunch of reading, and I had said we were going to talk further about antidysrhythmics. And I realized that over the last couple of weeks, we've talked a lot about cardiac medications. And if I made a last-minute change, it actually would change your reading assignment, and I didn't think that was particularly fair on Tuesday night to say, oh, by the way, go read these other 12 chapters. So instead, we will probably, at some point, if you want, go back and review some of the cardiac meds. But really, I kind of want to talk about this whole medication error thing. I've just did a quick search to see what's going on currently, and it is pretty distressing. But before I dive into that, what was the question you were going to ask me?
What's the Pharm case study assignments?
Oh, Pharm case studies, yes. So one of the questions that came up was, am I going to assign a case study for you on a drug? Yes and no. I'm going to assign a case study. But it's not going to be on a drug. It's going to be a case study. It'll be a patient in a situation receiving one or more drugs, and you're going to get to talk about it. You're going to get to explain to me why those drugs are being used, what their rationale is. Well, that's kind of... Bless you. She's allergic to class. The pharmacokinetics, the physiology of it all. So that the goal is that you gain a greater understanding of how these things all work together or compete with each other, or systems that work or compete with each other. Last week, I gave the midterm for MedSurg 2. You guys, you did well, and this group on the NCLEX part of the test did well too. I'm actually sort of stepping away from my concept map concept because I'm finding that people aren't really quite ready for that. But I started adding case studies instead. And I gave them a case study question on a transfusion reaction, and it was pretty eye-opening that pretty much everybody identified that it was a transfusion reaction. And then after that, pretty much everybody thinks that Tylenol is a miracle drug that you treat transfusion reactions with. Unfortunately, there's really almost no use for Tylenol in transfusion reactions, especially when you only have a 1 degree rise in temperature. It's like, what's the point? We need to be talking about diuretics and maybe blood pressure management, things to, maybe steroids, depending on the level of allergic reaction. People went off in some very interesting tangents. Partly, I think people are overthinking the question, making it more difficult than it really is. So I'm hoping in giving you similar assignments, we can really start working on thinking like a nurse, because you're not far away. And, if you enter the profession with sort of the right mindset, you're going to do really well. And if you get out there thinking in terms of Scantron, you're not going to walk into a room that has checkboxes about what's going on with your patient. So that'll, I want you to be as well prepared as possible. That's really where that's at. Did that answer your question about what the plan is? Oh, the other question related to that was like, when is it due? Because it's due the same week that we're doing the midterm. Maybe just a show of hands. Do you want to do before the test or after the test in that week? After? That's not a show of hands, but I'll accept that as after. Okay. So let's talk about medication errors. I was reading your summaries and comments, and you're all making, good observations. Did anybody just Google hospital medication errors? Which is what I just did here. To research. What did you find, if you did?
I put in studies.
So here's Here's the query that I did. Hospital medication errors, error statistics. And I think that these headlines are scary. New records. Medical errors, the third leading cause of death. What are the first two? Yeah, cancer and heart. So we're killing a lot of people in the hospital who might otherwise have survived if they didn't go to the hospital. I would be interested, actually, one of these days, maybe I will do my own little, semi-research. Are organizations that are using an integrated electronic health care record across both outpatient and inpatient, do they have an improved, are their statistics better? Since everybody knows what that patient is taking and the system self-checks and says, hey, doctor, that this patient's already on medication X, and you add medication Y, there might be problems. A lot of the hospitals still in the U.S. do not have electronic health records in place. They're working on it with great resistance. So what do you think about when I look at these headlines? Let's see if I can get there. I can't read this without my glasses. So medical errors are costing $1 trillion a year. That's a fair amount of money. But what I thought was particularly interesting, actually, are you all familiar with ISMP? The Institute of Safe Medical Practice. It's a really good website to go look for how to best do our job in a safe manner, for patient safety. It really is an official organization, and it's worth spending some time there. But what I was looking at, that's a great, death by medicine. Now, you all have read To Err is Human, but To Err is Human said 100,000 a year. Now we're talking 4 times that. Now, I don't know if that's in part due to improved reporting. That happens. As you improve the reporting systems, things can change just because more people know about it now. There may not have really been a major change in the number of hospital deaths. It's just back in 1999, they were only getting 1 in 4 that were actually being reported. And now maybe they're getting 4 out of 5 or whatever. But still, that's 500,000 people who had the bad fortune to go to the hospital and be killed by the staff, one way or another. I'm looking for your input. What do you guys think? What do we need to do differently? Aside from tracking with an effective EHR. So, some way of knowing what every person has prescribed for that patient, particularly while they're in the hospital. By the way, they've been actually reticent to do a study on medication errors or, polypharmacy, if you want, deaths outpatient, because they think the number is many times larger, where people are getting multiple prescriptions from multiple sources and then taking their own over-the-counter drugs. This is probably the smaller of the 2 numbers, but we haven't had the courage to really go explore that yet. But anybody want to? This is kind of one of our opportunities to just sort of kick back and talk. What do you all think? I'll be quiet for a while. I know it's early. Please. I know you have opinions because I'm sure you shared them with each other either via email or conversations. Share them with me. Tell me what you think.
I thought Anna had a really good point in her response that the different types of electronic charting systems can either reduce medical errors or increase them, and she was saying it more in general. Mm-hmm.
So like system-induced errors. Root cause analysis sort of tells you that.
Because you would expect like a reduction errors, but it's a really complicated system, and the nurses don't have enough time to get used to it.
Or the doctors don't. I mean, it's everybody in the chain. You got the doctors, the pharmacists, the nurses, everybody. There's an interesting thing. Now, are you aware that it takes FDA approval to write or change software for an IV pump? That's a medical device, just like software that controls planes is controlled by the FAA. And there's a whole bunch of rules and testing that goes on to make sure that if the software fails, the plane doesn't crash. Same thing with an IV pump. There is a whole bunch of rules and testing that goes on to make sure if that pump fails for some reason, it fails safe. Fail safe means that it goes into some kind of safe mode. Usually with a pump, it's probably just going to shut down and an alarm. Because if it's not pumping correctly, and you don't know what volume is being delivered, and you're working in the ICU and mics per kilogram per minute, where you're titrating every 5 minutes, to have a major pump failure is a big deal. Electronic health records don't have that requirement. Anybody can write an electronic health record. There's no rules about how error prone or how much testing. It's just, it's an opportunity to make a lot of money. So, your thought, the two comments here about EHRs, the quality of the EHR, the usability, is pertinent. I know I've mentioned it in previous lectures. I have really strong feelings about how bad every EHR is that I've seen yet. As a former professional software engineer, I look at these systems and say, typically they violate every rule I ever learned about a good user interface. They're poorly designed. They have way too much information. It's not laid out in any logical fashion. Too many screens to go to. They're dangerous. From my perspective, they're all dangerous. And while I'm used to Epic, it's only marginally better than Cerner. Cerner has, Cerner, some of you are, if you're up at North Bay with me, you're using Cerner, and a couple of other facilities I've been in use Cerner. Typically it's more with Sutter. Yeah.
What if they require it that all hospitals use the same system? And they require it that they use an electronic system?
Ask Congress. Well, that makes it a monopoly, for one thing. So, we're real averse to monopolies, unless you happen to be somebody who's in charge of the company that would have the monopoly. But, before your time, like the phone company, that was ultimately broken up because it was such a powerful monopoly. So the thought of saying, Epic Software gets to be the manufacturer or the software provider for everybody, it's not going to fly. At least, it's just not going to happen. But there are things you can do. You can say, well, every software manufacturer needs to meet these requirements. That'd be another decade-long argument about what those requirements are. Meanwhile, we'll have killed 4.5 million people. But that's the way it goes. Other thoughts, comments? Yeah.
I liked what Kristen wrote, and she was talking about how nurses don't take care of themselves, or there's nurse fatigue and all these things. And I ended up reading in this article that broke down a bunch of why nurses thought things happen.
Yeah.
And that's what errors happen. And one of them was 12.5-hour plus shifts. And that kind of struck me because last week when I went to clinical, my nurse was complaining about how the day before 3 staff members had called out sick in the ED, and so they were doing 12 hours
instead of 8.
Each person was stuck in their section, and it was a very crazy busy day, and nobody called, and nobody was.
There was no relief, yeah.
And so it's that's something that's very feasible that happens. So.
Analogous to that, back in my late 20s, I was a carpenter. And the Carpenters Union actually explored the idea of doing 12-hour shifts instead of 8-hour shifts. and they looked at the accident statistics. The accident rate dramatically increased after 8 hours. People were tired. They were stressed. So the union wouldn't agree to it. Basically, there were no 12-hour shifts, at least if you're a union carpenter, and I think it still may be true, because people were cutting fingers off, nailing their hands to the boards. I mean, there's a lot of, powerful equipment and dangerous stuff in carpentry, just like in nursing. And yet, we seem to have no real problem with the idea that, I used to work 12-hour night shifts. How good I was between 4 and 7, was I? Well, I was already struggling just because, sleep deprivation, change of being outside of my circadian rhythm and all those things. But it would be interesting to see if there are studies on, what is the accident rate or error rate in the last 4 hours of a 12-hour shift. They have actually done studies, the whole thing with residents and their residencies and these 24-hour on shifts. And while the medical schools and hospitals in particular are sort of fighting back because they don't want to pay the extra money, the studies are pretty clear that the mistakes are made. The longer you work without sleep, the more likely you are to make a significant error. So if you're working in that ED and the doctor next to you has been there for 24 hours, it does put an extra load on us as nurses to say, does that order actually make sense? Things do happen. Did I tell you all about my error with propofol? You don't remember? Yeah, okay. Well, so we were qualified to take patients directly from the OR. So they didn't necessarily go through the PACU. They could come straight to the ICU. This patient actually kind of went to the PACU for about 3 minutes. It was 4 a.m. The nurse wanted to go home. And so she said, can I bring the patient up and, let you'll get to recover and I'll help you get set up and then I'm out of here. I said, sure. What the heck. She'd had abdominal surgery, I believe, like colectomy, something of that sort. But she was on propofol while she was on a vent. And so we're setting everything up, and I programmed in the propofol and, kilograms per mics per minute, or mics per kilogram per minute, blah, 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 and we're doing this. And how long is by the way, just out of curiosity, how long is a line with propofol running through it good for? How often do you have to change that line? Nobody knows? Is propofol a good bacterial medium? Yeah, it's basically lipid-based. You change the line every 12 hours. So everybody marks their lines. If they got propofol running, you make sure that everybody knows that, you're going to change that line in 12 hours. It's important. That wasn't my mistake. What my mistake was, and she didn't catch it either, because it's not really a high alert drug, was that I programmed it off by a factor of 10. She was getting 10 times more propofol than was ordered. About 2 hours into her recovery, I started noticing that, her heart rate she was getting increasingly bradycardic. She was getting down to the 40s, and I was starting to say, this is not good. What's going on here? And I'm in the room, and I'm looking, I thought, why is that bottle so empty? Because it shouldn't be running quite. I shouldn't be 3/4 of the way through a bottle of propofol in just a few hours. And I went and back double-checked. That's when I found out that I had overdosed her. And actually, one of the stated side effects of propofol overdose is bradycardia. When I gave her the proper dose, her heart rate came right back up and all was good. Still had to fill out, my RRF, had been even done on okay, Kaiser, they're called, responsible reporting forms. Otherwise, some places they'll be called unusual occurrence, UORs or whatever. And none of you have had to do that yet? Good. I'm glad, actually. It's no fun. But It's actually fairly easy to make these errors. You're tired, you're in a hurry, there's lots to do, and even though we were using the Guardian pump, somehow it didn't flag that I was overdosing the patient. So I sort of come to rely on the system as well. You know, these sophisticated pumps will tell you, that's outside the normal dosage. Why it didn't, I don't remember. It escapes me. Or if there was a problem with the pump. Actually, we were using Baxter pumps, which I understand nobody's using anymore because of a massive lawsuit because of errors with their software or firmware. Anyway, back to you. What else have you observed, either in your experiences in clinical, or read about that caught your attention? I mean, thanks for bringing up. Yeah.
When I was at Kaiser, they had the sashes that you're supposed to wear.
Right.
And I think that the nursing students were overlooked that where Leslie was an instructor. Leslie, so she would make us wear them, but all the nurses wouldn't. Maybe I saw like one nurse.
Yeah, it was, when it was first, I was working for Kaiser when they first instituted that. And it was met with actually a lot of resistance, particularly in critical care. On the floor, less so. What was the intent of the sash? Do you remember what they're... More than just know. What does it actually indicate you're supposed to do? Not interrupt, particularly in the medroom. So like, at the Pyxis, there's even an additional, yellow lines that, in theory, when somebody's standing at the Pyxis pulling drugs, you don't talk to them at all. You're not supposed to. It's a reminder to the doctors. Critical care, I don't know why. We just felt... I still have my sash at home. And I actually rarely wore it, at least on the night shift. Why? I can't really say, except it's a little bit of that, I'm going to resist authority, I guess. Child of the 60s. Yeah.
I was in the same clinical group, and I had one of the nurses actually make a comment or something like that's one of the stupidest things I've ever heard of, about having to wear the medical sash.
The rationale actually made sense. I think there was something about the implementation that didn't work. And they did not get the nursing staff to buy in for whatever reason. Why, as an overall plan and policy, it really has not taken hold, I don't know. But I do agree, and particularly on the floor, it happens less in critical care because, I'm going to the medroom all the time. There's things going on. Not only do I have regular meds, but if a patient's crumping or whatever, you're just busy. On the floors, I'm sure you've seen that, there's a significant level of interruptions. Somebody's walking down the hallway with, meds in their hands. And, oh, by the way, June, what's the plan for dinner for this patient? Is that relevant to what June is doing at the moment? No. So instead of being focused on I'm giving meds to this patient for this reason, there's something to think about dinner for somebody else. What else have you observed that you think? Do you have thoughts about, you've both commented yet on, that the reaction of the nursing staff, most of them not using it, one actually actively saying that looks dumb or stupid. Was that a traveler or was it an actual Kaiser employer? Do you know?
I forget. And when we passed meds, we used them, she's like, we'll do it for you because you're a student, but...
Don't bother us the rest of the time.
She was just kind of like, I never use this.
Right. Do you have any of you that had been at Kaiser, any thoughts about why it has not been adopted by the staff? Why would you resist a safety item that is to the benefit of both your workflow and your patient?
Maybe it just hasn't happened to them, so they're it's not like it.
That's an interesting comment. So you think most of those nurses have never made a med error? We all make med errors. Most of them we don't even realize.
I think it's just tedious, to put a sash on that I bet people don't. Who wants to talk to you?
It's a pain in the butt, actually. Yeah, it was an extra thing to do already. So maybe that was it, just the inconvenience of it all. Then we had to insist that they be breakaway because you can't have things that patients can grab onto. Yeah.
I just wonder what it like differs from every institution, because I remember at CPMC, the PAT campus, they were all happily wearing the orange belts, and those looked horrendous. It was tedious to put on just as well. I just wonder.
Yeah. What's the different culture? You know, the corporate culture. Interesting. Yeah, it's an interesting. Well, and which Sutter facility?
The CPMC, California, and PAT campus.
Okay. So if you go to Sutter's Santa Rosa, they don't wear them.
No, they don't. That's right.
Typically. So, you know, yeah, and one of the differences between say, Sutter and Kaiser, well, you're all aware that Kaiser is actually 3 separate entities that work cooperatively. Or do you know that? There's the medical group, which is for profit, by the way. There is the hospitals, and there's the insurance company. The hospitals are not for profit. The insurance company is for profit, and the medical group is for profit. They make money. The hospitals are the only nonprofit portion. Each hospital is actually its own entity. They, again, are a cooperative group, and they sort of agree amongst themselves that they're going to implement the policies, and the doctors agree they're going. You know, they have a set. Basically, the Kaiser Permanente Medical Group, and the first one, by the way, which was formed in Northern California, is called TPMG. Anybody know what TPMG stands for? The Permanente Medical Group. All the others are actually called like Southern California Medical Group, but in Northern California it was just the medical group. That's us. We're the kings. So the medical group basically contracts with the hospitals to provide their services at a set rate. Sutter is a much looser organization. Really, every hospital is its own entity, and they have multiple medical groups that they're dealing with, and each medical group negotiates its own contract. So compensation for physicians is different, even within the same hospital, depending on which medical group they belong to. Anyway, back to the actual topic of medication errors, med safety. What other comments come to mind? Yeah.
Well, I'm at Kaiser Centerville, and I had a patient at 9 a.m. She had like 9 meds that had to be due. So I was following my nurse as she was doing it. You know, she didn't want the stash or anything, and she didn't even write down her meds. And I asked her, I was like, okay, like, what's your system? Because
her system was to go to the Pyxis and pull what was available.
Basically, because, you know, at Kaiser, it's like you have the Pyxis screen and then you have the order screen.
You're supposed to bring them both up at the same time.
She wasn't using the order screen.
Okay.
I asked her, I was like, well, how do you
know that the orders haven't changed?
Out. And she was just saying, well, as time goes by, you're just familiar with your meds. And
so what's the danger with being familiar with your meds?
The order could have changed.
Yeah. Now, if it's been DC'd, you're probably okay, because Pyxis is going to know about that. And it's not going. Suddenly, you're not going to have that drug available to give.
And that's something else I asked her too. I was like, well, how do you know if you're taking out the right dose? Like, how do you know if you need 1 tablet or 2 tablets? And again, her answer was just become familiar with it because she's had that patient before.
So she trusts the system to save her butt.
And she trusts her own memory too because she's had that patient.
But memory. So the problem with memory is you may be remembering something that's no longer valid. They may have added. So one thing that Pyxis won't tell you is that what meds are due. Yeah. That's what that order screen says. Here's the meds that are due. So if you're not looking at that and doc wrote new orders starting something, you're not going to give it because you didn't look. Now, of course, you know, Epic says there's, you know, orders to be taken off, orders pending. There's a number of places in there to help you remember. And that's also, you know, why in the training for Epic they tell you not to do the nurse's brain thing. Don't write anything down. I never could get past that. I always had some notes about my patients, regardless of the system. For one thing, after all my years in software, I don't trust systems. completely. They go down. And if the system goes down, where are you going to look if you don't have your own notes? I mean, that was my safeguard in part to know. Of course, orders could change during, that's a code white when the system goes down. That only happens it happens regularly, like once a month, on nights because they do system maintenance, and the system will go down for like 5 or 6 hours in the middle of the night. So if you don't already know your orders, you're in trouble. But yeah, that's a good point. Other thoughts? Yeah.
I'm at Rare General, and
They have the worst system in the world.
they have, at least I was on the cardiac floor, and they have 2 Pyxuses in the med room.
Right.
And some meds will be in one, and some will be in the other.
That's actually true in Kaiser in the ICU and cardiovascular ICU as well. Partly it's just because of space limitations, and then there are certain meds that have to be refrigerated and some that don't. And so part of that's just the mechanics of it. But yes, you need to know which Pyxus to go to get that.
Yeah, like sometimes it'll be carried out on one,
and it's active on the other. And so they tell you, oh yeah, I got to go look in the other machine.
Yeah, and then sometimes they don't go back and look at the other one, or sometimes it won't even be in either one, and then they have to call.
Then they have to call the pharmacy and say, I don't have. And by the way, there's a lot of drugs that, if they're on a continuous trip, like on a cardiac floor, you're not supposed to stop it. It's like you always want to make sure you have a bag available for whatever that drug is. Are there other things in the Pyxus that you can't normally access? Do you know how to, how to get the injectors for the Carpujects? That's actually, it's kind of like off formulary kind of stuff. There's a way to get there. How are we doing on time? Well, I got plenty of time. What other thoughts, observations? Yeah.
Just also like the different Pyxus themselves. Like some of them you just pull out and they're just drawers. Like it's just drawers with medication.
That's because they're not controlled.
Yeah, and then others are like the ones that have like the flap.
Those are usually meds that are counted.
Yeah, so I think it's just interesting because, like I was in the ED and it's just, we went through like a couple of drawers and it's just all stuff that was just like open.
Right. So if you needed to grab a little extra Tylenol for yourself, you can. Probably not ethical. It's been known to happen. I've seen nurses go in, they've got a terrible headache, a migraine or whatever, and they'll open up a patient's record and the drawer will pop out and they'll pull some Tylenol and then tell Pyxus, oh, that was a mistake, and just put it back. Because the system, since those, like you say, those boxes are open, there's really no way to track that. To get the narcotics to open, you have to actually open the narcotics. Then the count's going to be off, and that's a problem. It also says who used it last. And I'll get to you in a second. The other thing you need to, just procedurally, you really, really want to remember, always log out. Because if you forget to log out, particularly once you have your RN, and somebody walks in behind you, and you're still logged in, they can go get those narcotics, and guess who's going to get blamed? You. I've seen people fired for it. Yeah. What was your question? Comment.
Difference that I noticed that we're at CPMC St. Luke's, and I can't remember if it was like this on the telemetry floor. I haven't been in the ED or the ICU, but on the subacute floor, the LPNs have to count everything, like whether it's a narcotic or like Colace or I don't know, whatever. They have to, like, even the open ones, they have to, the computer asks them to count.
So that's cost control. And I'll give you a background reason. I'll give you a background reason as to why. Are patients at Kaiser charged for individual meds? No. At Sutter they are. Because you scan everything. That aspirin costs you $5, by the way, per tablet. Yeah.
Yeah, because all of their
all their supplies.
All their supplies now are locked in by nurses because they want to make sure that the patients are being charged right.
Right.
I thought it was about making sure they're getting this right.
No, it's about charging the patient. It's about making sure they get their money. It's always about the money. I hate to say that. It sounds so cynical, yeah.
The thing I was going to say is it seems seems like there might be ways to improve systems and everything so that med errors don't happen, but I don't know how to fix this because you can't stop people from being careless, and I don't think the nurses or the healthcare professionals don't care, but they're just doing this every day, and it doesn't seem like a big deal to them. Like getting meds, they do it however many times a day, or writing meds, or the pharmacy brings stuff up to the pick list. It just becomes such a routine that people, a lot of the stories people are sharing, the nurses just kind of like no big deal.
Sure.
It's part of the job.
So that's your challenge, is to remain engaged enough that when you're looking at the meds that are due for your patient or the new orders that have been written, to actually ask that question: why am I giving this to this patient? Why did the doctor order this? Does this make sense? And if you can't find a rationale for it, it's okay to call that doctor up and say, I don't understand why I'm giving this. And there will be occasions where you get chewed out. There will also be, hopefully, occasions where the doctor says, I was thinking about somebody else. It happens. I've told the story about vecuronium in here, haven't I?
Yeah.
Some have, some haven't.
Is that the one that they took up to the med surg floors and not supposed to go to the
Yeah, they took. So do y'all remember what vecuronium, pancuronium do? What they're called? They're paralytics, and they shut down all involuntary muscle movement, which of course includes breathing. So this was a situation right after the electronic health record went in, and a patient in the ICU was bucking the vent. The doctor in the clinic had 2 records up at the same time, ordered this paralytic for the patient that's on the med surg floor that doesn't have any vents and everything. Ultimately the nurse hung a bag that he or she didn't know what the drug did. Didn't know that patient wasn't going to be breathed after they started that IV. Luckily, the patient survived. You had another comment or question? I saw the hand go up for a second. Okay, vecuronium or pancuronium. I don't remember which it was. It might have been pan, but they're close. They're both derivatives of curare, which is what they use in the Amazon to bring the monkeys down. Or if you're Indiana Jones, it's they're wielding for you. Okay. In the Temple of Doom. No, okay. What other? Yeah. I don't care, as long as it's about patient safety and medications.
Yeah, sometimes I've seen and heard of too many cooks in the kitchen deal.
Okay.
There's too many specialists ordering different things, but they're not compatible with the
Right.
cardiologist and whatever.
The renal specialist.
Yeah.
Those are big conflicts frequently. Or you've got a neurologist and a cardiac specialist. Everybody is, in their own kingdom. That happens more in the private hospitals because they are sort of each. There's a certain, what the term when you talk about it, what a silo is. That this thing doesn't talk to this thing, and that was one of the hopes for the electronic health record and the ordering systems is the system would catch when you've got 2 people ordering something that's in conflict. Kaiser has just such a different organization that it really does improve outcomes in that regard because they really do have a team approach, and it's generally pretty successful. I saw hands over here.
Oh, just when I was doing my response, I found a pamphlet that something interesting to every patient where it was these are all the situations that could happen in a hospital or at home from pharmacy.
So make the patient participate in their own safety.
It was you need to have an up-to-date list of meds, including over-the-counter and herbal remedies. Don't let the nurse give you meds if they haven't scanned you. If you don't recognize it, ask if you need to know.
Should you explain what you're...
You can do that, because some patients don't.
And should you, as the nurse, explain every time you're giving the same meds every day to the same patient, what it does every time? Yeah, you need to, that's part of your job. Yeah, Kaylin?
I was just going to say that my nurse that I had on Friday at the VA, every patient that we walked in the room for and handed meds to, she was asking, do you know what meds you're on? Do you know what they're for? Do you know what they look like? And she was quizzing everyone and telling them what it was for. And one patient actually said that he was on a higher dose at home than what he was being given. So like we were able to talk to like the cardiologist and stuff because of that. So he actually was like an additional line of defense.
Exactly. And, you know, there's a lot of education to do for our patient population that, you know, you really should be participating in your care. This has not been our cultural norm. You know, it's whatever the doctor tells you is what you do, or nurse practitioner. And now we're saying, well, wait a minute, you know, you should be paying attention too, because somebody could make a mistake, and it's your life. How are we doing on time here? Somebody want to talk for 10 minutes? Okay, go.
Just kind of what Mackenzie was saying with people ordering everything. You said you worked with software. Would there be a way to make it so that the software would notify you if meds are being ordered?
Well, that's what Epic does. Well, you probably haven't seen that part of the system because you guys don't order meds. But it's built into Epic and Cerner. If you are an ordering entity and you start placing orders for meds, it comes up with a hard stop and says, you know, there's problems with this, the patient has allergies to it, or they're on some other med that's contraindicated, and whoever is ordering has to either override it and explain why they're overriding, which is usually the benefits outweigh the risk, or they cancel it. They get switched to another med. And in theory, the pharmacist should also be double checking. Hey, doc, I see that you overrode that. You know, I don't know that happens as often because that gets into that other realm of telling the doctor they don't know what they're doing. But who's your best resource when it comes to meds? Is it the doctor? That's the pharmacist. They actually know those meds. My only problem with pharmacists, for having worked directly with them and under them for 3 years, was they have a very narrow view of the patient. They're not holistic. They are thinking about those meds, and that's it. They're not even thinking about the impact on the daily life, you know, what it's going to be like when that patient goes home. I mean, there were some decisions I saw being made in the outpatient pharmacy or the IV pharmacy that were like, yeah, but they can't do that. You know, your expectations of the patient are way out of line with what they're capable of doing. Anyway, who wants to cover the next 6 minutes?
Talking about in her response verbal orders, and I don't really think verbal orders are given that much anymore.
They're highly discouraged.
But I've seen like doctors, like you talk to the doctor and they need to put an order in, and then nurses are like waiting around for the doctor to put the order in. And Marin General has a really bad charting system, but they use like iPod touches to text the doctor. Yeah. And then like whatever they text goes.
Like, I'm still waiting for that order, doc.
Yeah, but I think if you order, like the doctor texts them the order, they can like, I think it like goes into the chart.
I get maybe they can consider that a telephone order. It is, if it's written by the doctor, there's very different rules. Okay, now you guys don't get to take orders, so you don't have any experience with this. But Kaiser does, even though it's discouraged, but they will allow for the nurse to take telephone. First, I should back up. What's the difference between a verbal and a telephone order? A verbal order is the doc sitting next to you and says, oh, by the way, get Tylenol for Mr. Jones. That's a verbal order. You know, the expectation is the nurse is going to sit at that system and actually order, you know, put the order in for that med, for dose, frequency, you know, and everything else, which is, hey, the doctor's sitting there. Why, you know, what's your problem? Telephone order is the doctor calls. And the intent, as it was explained originally, is doctor is on their way home or in transit, in surgery, cannot actually physically order the medication. Therefore, and the situation's urgent at some level. If they're at home, all the physicians at Kaiser have access from home to write orders. So in theory, they're not supposed to call in a telephone order from home. They're supposed to just write the darn order. How did we get on this? What was the question? Oh, Marin General texting.
You couldn't, they could mess up the order, but if it's a text, you couldn't, you know what I mean? Like, you can see the name, you can see the dose.
Yeah, but if the nurse is required to actually do the order entry, then we're getting back. So what is you have, like I said, you haven't done this yet, but when you get trained, what the procedure is, Have you all read about what's supposed to happen on a telephone order? So what's supposed to happen is, Dr. Jones calls up and says, I want this, this, and this. Your responsibility and hospital policy in every hospital I've been in is you read that order back word for word and get the doctor to confirm that what you read back is what the doctor said. In terms of dose, frequency, parameters, all of that. And if you're not doing that, you run the risk of, I don't generally transpose numbers, but it does happen. Hey, I managed to overdose a patient with propofol 10-1. So things can happen. And if you're scribbling notes, because you're not really writing the order at that moment, you're making, just jotting notes down, and you make a mistake. If you don't read it back, the likelihood that you're going to make that mistake goes up. So that's usually when you take a telephone order is you have to read it back, and you have to acknowledge at the time that you place that order in the system that you read it back. And if you didn't, then you can be terminated for false charting. What have we got, like a minute and a half? 4 minutes. What's up next? Any other closing remarks, comments, thoughts? Any thoughts about that 500,000 people that are dying every year in the hospital? Doesn't that terrify you? Do you want your family members and loved ones in those facilities? I had a friend actually it wasn't a medication error, it was just bad medicine, her father went in for bypass surgery, and he died 5 days later of a massive infection because nobody was running. They weren't taking CBCs. Yeah.
I just wonder. I wonder what the hospital situation for nurses is in like Spain and Japan, because they advocate for the siesta in the middle of the day, or Japanese at the workplace they're supposed to take like an hour nap in the middle of their shift. So I wonder if it's like that in hospitals.
In terms of fatigue and stuff, that's an interesting question. I have no clue. I do know that in many of the industrialized countries, you have to have a master's as entry to practice. A bachelor's is not sufficient. And none of this 2-year ADN stuff, that gets you to be an aide in many countries. You actually have to have a master's of practice. And when they did the studies about morbidity, mortality, and patient load, it actually, in those studies, said that the master's prepared nurses had the lowest rate of errors and judgment errors. That the patients were safest in the hospitals that had the more highly educated nurses, and especially BSN, MSN. Those patients did better. And part of the difference for that, my personal belief is, your training and my training leaned fairly heavily on theory. At least I hope so. I don't. The thought is that you know the underlying reasons, or should know the underlying reasons of pathophysiology, so that if there's alternatives, you will think of them. The training for the ADNs is very much technical. The doctor orders this, you do it that way. And they don't really have those options that say, well, there's actually 3 different ways we could do this, which you may have learned, I have learned, but often they've not. So they don't have that option to go back and say, it'd be better if we did this for the patient. Anyway, that's just editorial. So we got a test coming up in a couple of weeks, which means I really have to sit down and write all the notes for the lectures. There probably won't be lecture notes for this one because this isn't a lecture. But I appreciate all your responses. I'll go through and give you appropriate grades, which so far, just one passing comment. The instructions were for more or less 300 words. When you guys get down to 250 words, I'm feeling a little awkward about giving you full points for that. But since I didn't really emphasize that at the beginning, I'm going to let you slide this time. Next time you'll notice it says 300 to 350. So if you're under 300 words, I will grade you down. I will. I know that's really picky, but it's the truth. Any other questions before we blow out the door? Or those of us that are leaving, leave? Yeah.
I haven't done the responses yet. It's due at 23:55 today, right?
Is it, well, I hope so.
According to the.
Because if you haven't done it yet, it just won't let you record it.
Oh, okay.
Yeah.
Oh, if it's closed.
If it's closed, it'll tell you. I'm sorry.
Okay.
You missed the deadline. I thought it was 23:55 last night, but I don't remember.
It said the 16th.
Is that today? Then you must be good to go. Okay. Thank you all.